Good afternoon. Welcome to our webinars. I'm Chen Qianyu, the Director of the Center for Innovation and Precision Eye Health. Today, I'm very glad we have Professor Padmaja Senkri-Dirk with us. She is the head of Global Myopia Management Program at SAIS and also a co-joint professor at the University of New South Wales, Australia. Over the years, she has been working on several projects on myopia and is an inventor on many patents and applications related to myopias. And today, she is going to share with us her rich experience and research work on myopia management. Professor Padmaja, the stage is all yours. Thank you.
Thank you, Professor Cheng. I'm going to share my screen and get the slides up and running. Good afternoon, everyone. I'd like to start by thanking Professor Cheng for the kind invitation to be part of this webinar series. It's an absolute pleasure to take part in this series. My affiliations and disclosures are listed on this slide. Before I start, I wanted to acknowledge the many colleagues and collaborators who were instrumental in part of the work that I will be presenting today. Much of the work that I'm presenting today comes from my tenure at the Brian Holden Vision Institute, so a special thanks to BHVI. What I thought I will do for the next half hour is take you through two of the areas that I've been involved in recent years. Firstly, looking at the utility of axial length values in myopia management, and then a novel and exciting application looking at a combination of atropine and caffeine for myopia management. Firstly, looking at axial length values, we all know that when we talk about myopia, we are talking about an eye length that is longer than normal relative to the focal length of the optical components of the eye. And we know that an increased eye length underlies the pathological signs of myopia that we see, for example, myopic macular degeneration. However, when we look at the definitions with respect to myopia, and here I've put in the definitions from the two peak bodies, WHO and IMI, we can see that myopia has been defined with respect to spherical equivalent refractive error. There's a small difference when it comes to the definition of high myopia, but again, spherical equivalent refractive error is the focus. However, we do know that spherical equivalent refractive error is an important measure for us to consider because it defines the start of a prescription as well as the change of a prescription for the patient. So it's useful to say that a person is myopic. It has a relation with vision and therefore it is a functional outcome. For example, when we talk about -1 diopter myopia, we know that the visual acuity is somewhere in the region of 6.9 to 6.12. And also, it's quite a useful measure to convey the state of the eye or relay the progression to individuals. We might say to a person, look, you're -1 diopter myopic, and then when we say -4 diopters myopic, they understand very well that the condition has increased in severity. However, when we look at the repeatability of refractive error measurements, what we see is that, especially with respect to subjective refraction, we are looking at variability, which is as much as plus or minus 0.5 diopters. And this variability increases with respect to non-cycloplegic refractive error measurements. When we look at cycloplegic refractive error measurements, we can see that they are more accurate. However, we do have an issue when we start comparing between instruments and techniques. In comparison, when we look at the repeatability of eye length measurements, especially with the modern day biometers, what you see here is that these instruments are highly accurate. And when we look at the repeatability and convert that to spherical equivalent measure, we are looking at as little as 0.12 diopters. Therefore, the question is, can we use axial length measurements, firstly, to screen or detect myopia? And secondly, how well can we use axial length measurements to monitor myopia as well as assess the risk of progression of myopia. Now, going back to the spherical equivalent refractive error data, just for a little bit longer, what we have here is data that we looked at with respect to children aged 4 to 15 years from a center in Shanghai Eye Disease Prevention and Treatment Center. What we did was to look at the difference between cycloplegic and non-cycloplegic refractive error. And what we see here is that the difference is much greater when children are young. So in children as young as 4 to 5 years old, we are looking at as much as a diopter in difference. And we see that the difference when we look at refractive error categories, the difference is more for hyperopia, emmetropia, and low levels of myopia. When we look at myopic refractive error of about -3 diopters or children aged 15 years and over, this difference seems to be minimized to about 0.3 of a diopter. However, it is not as simple as saying we should transfer over and do cycloplegic refraction, because we know that in many of the countries, many of the eye care practitioners do not have access to diagnostic drugs, including cycloplegics. And we also know that cycloplegic refraction takes time and resources. So in that respect, what people have been doing is to try and see whether they can improve the value of non-cycloplegic refraction. For example, people have been looking at using a higher threshold to categorize that condition as myopic. So here we can see that a -1 diopter is used. In other trials and studies, they not only used a higher threshold, but they also try and combine it with uncorrected refractive error. So here, for example, in terms of trying to detect the prevalence of myopia, you can see that there is improvement when we go from just using non-cycloplegic refraction with a higher threshold to including uncorrected VA as well in the equation. Now, again, in a study that was conducted out of Shanghai, what they did was to look at 4 strategies for the net benefit. So here they looked at cycloplegic refraction, non-cycloplegic refraction, uncorrected VA alone, as well as distance visual acuity, and combined that with non-cycloplegic refraction. And what you see in this graph here is that irrespective of the probability of developing myopia, cycloplegic was the most accurate in terms of detection of myopia. However, when it comes to what we call the net benefit, what we see is that non-cycloplegic plus visual acuity had the highest benefit. And that can be explained because cycloplegic refraction not only takes extra time and resources, but we are also talking about the fact that, for example, when we use cycloplegia, the child is going to experience blurred vision for a certain period of time. So impaired vision for a certain period of time. There's going to be time involved with respect to carer responsibilities. And we also know that cycloplegic refraction carries a risk of complications. So in other words, we are looking at a way to be able to detect myopia using a value that gives us the highest benefit. So in that regard, let's take a look at whether axial length measurements are going to be of value for detection or screening of myopia. So here's some data. We've got n equals 29,000 eyes, Asian eyes. And when we plot it and when we look at what it means in terms of axial length and refractive error, we can see that axial length alone is not going to be useful to detect myopia. For example, when we look at planar refractive error, the axial length values range anywhere from 21.5 to 25.5 millimeters. However, when we look at this data a little bit more closely, trends start to emerge. For example, for axial length values of greater than 25.5 millimeters or 25 millimeters, we can see that there is a high probability of the eye being myopic. In addition, when we start to categorize the values and utilize other variables, then we start to see certain patterns. We know that the axial length values increase with age. And what we see here is that for a given age, the female eyes tend to have smaller eye lengths in comparison to males. When we then add corneal curvature, what we are seeing here is that, again, females are having steeper corneal curvature in comparison to males. And then when we consider the axial length over corneal radius of curvature ratio, AL by CR ratio, what we then see is that for a given AL by CR ratio, the female eyes tend to be more myopic than males. Now we can start to utilize this information in a model and see whether we can detect myopia. So we created one such model where we used axial length, ALCR, and then clearly we used the age and gender. And what you see here are certain patterns that begin to emerge. So if you look at ALCR ratio less than 3, and where the axial length is less, there is less likelihood of that eye being myopic. Conversely, where the ALCR ratio is more and the axial length is longer, then it is highly likely that that eye is myopic. What we then did was to compare the sensitivity and specificity of this model to the models that I presented previously, which is non-cyclorefraction and non-cyclorefraction with visual acuity. And what you see is that the sensitivity and specificity of this model is as good as using non-cyclo with VA, which we saw previously had the highest net benefit. In addition, when we're talking about using axial length values, we know that axial length measurements are more rapid, they're non-invasive, and we also saw that they're more accurate than non-cycloplegic refraction. So what we're seeing is that it is possible for us to detect or use axial length values to screen myopia in high-risk populations. At the present time, it is not, with this information, we cannot diagnose myopia, but we can detect the presence of myopia in high-risk populations. What we also know is that we have to develop these models for specific populations because we see that there are ethnic differences in terms of what we are seeing with axial length. So that's with respect to detection of myopia. What about utilizing axial length values to monitor the progression of myopia? In this regard, as many of you know, we started to use percentile curves. And what we did a couple of years ago was to take a look at a set of Asian data. So we had about 14,000 eyes, ages ranging from 4 to 18 years, coming from 3 studies from China. And we looked at age, gender, axial length, keratometry, and cycloplegic spherical equivalent refractive error. And initially, we constructed the AL and the ALCR percentile curves using what we call the LMS method. We also estimated a spherical equivalent at a later age using a model that incorporated age, axial length, and ALCR. And then we validated the model with an independent data set. And this information has been published, and it appears in a couple of biometers which have tools specifically to monitor progression. So just simply looking at the data, what we see here, again, we need to have specific models for males and females because we saw that there were gender differences with respect to axial length. What we see here is that at the younger age, at 4 years of age, the spread is very small. It's only about 2 millimeters. But by 18 years of age, you can see that the spread is quite large and it expands to nearly 5.5 millimeters. And then with respect to the Asian eyes, what we see is a year-to-year variation across all of the percentiles, except the third and the fifth percentile, or only the two lower percentiles are showing some sort of stability. With all the other percentiles, they're still showing an increase in axial length even at age 18. If we now compare this to a European data set, what we see is that at the younger ages, the data looks very similar. At 4 years of age, the axial length as well as the spread of the axial length looks very similar. But thereafter, where the Asian set diverged, and when we looked at this data a little bit more closely, we see that that divergence seems to happen at about 6 years of age. We see that the European data tends to be much closer. And the spread at 18 years of age, with the European data, we go up to 24 years. But if we look at the comparative ages, 18 years in the Europeans versus 18 years in Asians, with the Europeans, we saw that the spread is much lower, and it was only about 4 millimeters compared to 5.5 millimeters that we saw in the Asian eyes. In addition, the year-to-year variation in axial length was much lower in the European eyes in comparison to the Asian eyes. And we see that a lot more of the lower percentiles show stability much, and again, slightly earlier on in comparison to what we are seeing with the Asian data set. So how might one use these percentile charts? They're very easy to read. Everybody is familiar with the percentile charts. And here it helps us to rank both myopes as well as non-myopes. So you take a look at the eye and you take a look at the axial length. It's a quick and easy reference to see where they are in the population. And it also helps you to assess a future risk of progression. Now, with respect to a practitioner looking at this data, they should not just look at the axial length value. They will need other information, such as the spherical equivalent, so that they can then decide whether the eye is myopic and what sort of treatment strategy they might want to implement for that particular eye. Now, there are some limitations with percentile curves, and we already went through it. They are very much population specific. I say population because even in a certain ethnic group, variations depending on the regions. For example, when we look at China, we know that the prevalence as well as the progression of progression of myopia in along the eastern seaboard of China is much higher than when we look at regions which are situated into the western parts of China. So here's what I call population and gender specific. And there seems to be an assumption that when one falls on a certain percentile, that they will continue to progress along that percentile. However, that might not be the case, because when we are talking about percentile curves, we do not have percentile curves which are longitudinal based. Or in other words, we have not taken children 4 years of age and we did not monitor them into adulthood. What we have is specific ages, and then we split them into percentiles, and these percentiles are stitched together, which means that it is possible that they might not fall exactly along this percentile as they progress. And what it means is that it might not be very helpful to the practitioner if they see that if a particular eye, which is on a certain percentile, has jumped or changed percentiles. So let's say if somebody is on the 40th percentile, if they moved from 40th to 44th percentile or 45th percentile, there is no guidance at the present time for the practitioner as to what they might need to do with that particular case. But there is some data that the field is moving towards too, and we had also looked at this data, and this is what we refer to as normative progression data. So this data comes from 8 longitudinal studies from China, approximately 5,000 eyes, ranging from 6 to 16 years of age, and we categorize them into myopes, non-myopes. Here, non-myopes further split into emmetropic eyes and hyperopic eyes, but it's better to categorize them into non-myopes. And then we also have incident myopes. And as everyone knows, we see that the myopic eyes are progressing much more in comparison to the non-myopic eyes. But what these lines suggest is that with age, you can see that the progression for both the myopic and the non-myopic eyes are beginning to come closer. What we also see from this data is that the incident myopes seem to have progression rates which are very similar to that of myopes. Now, what we can do is we can now use this information for a particular eye and look at the progression relative to the myopic growth and the emmetropic growth. So here's an example where you take a particular eye and you can see that this particular eye is much closer to emmetropic growth than the myopic growth. And if at future visits they continue to progress along these lines, then the practitioner might be satisfied that that child is doing well and that the progression has slowed to be much closer to what we refer to as emmetropic or non-myopic growth. One thing I also have to mention with respect to this normative progression graphs is that as with the other data, we find that there is an influence of gender and parental myopia, but the influence of gender and parental myopia on progression is much lower in comparison to the influence that age has on progression. And surprisingly, what we found was that with respect to females, it appears that there is greater influence in non-myopes in comparison to myopes, or in other words, they showed a slightly faster elongation with respect to non-myopes. And we also have other data which shows that when you look at ethnic differences, there are ethnic differences with respect to the myopic eye growth, but the differences with respect to non-myopic eye growth are very close. So this particular progression curve is useful. So percentile curves are useful to show to parents and individuals as to where an eye sits with respect to the population, and people are able to visualize very clearly as to what's happening with that eye, whether they're at the extreme levels or whether they're in the normal range or whether they're down below. These normative progression graphs are more useful when it comes to instituting and monitoring progression for individual eyes and to tailor the treatment as necessary. So in summary, when it comes to axial length measurements, we see that axial length measurements are rapid, non-invasive, and more accurate than refractive error measurements. We also saw that axial length values do have potential when it comes to screening for myopia in high-risk populations. When it comes to monitoring the progression of myopia, we have two categories at the present time: percentile charts, which use the absolute axial length values and which indicate where an eye sits within a particular population, and it helps you understand how the axial length is changing over time. And we saw that they're very specific in terms of gender, ethnicity, what I refer to as geographic location specific. We also see that we now have a category called normative growth curves, and they may be used to monitor progression relative to the growth that you see in myopic and emmetropic eyes, and it helps the practitioner tailor the treatment strategy appropriately for that given individual eye. So that's with respect to axial length measurements. And what I'm going to do for the remaining 15 minutes is talk through a novel application for atropine in combination with caffeine. And here I'd like to acknowledge the efforts of Dr. Huy Tran, a pediatric ophthalmologist from High-In Eye Care, Vietnam, who came in to do a PhD with me being his primary supervisor working in this space. So looking at atropine, again, all of us are familiar with what atropine does with respect to managing myopia. We know that the higher concentrations of atropine are more beneficial in slowing myopia. However, higher concentrations of atropine come in with the side effects in terms of reduced amplitude of accommodation as well as an increased pupillary diameter, which leads to subjective symptoms of blurred vision, as well as photophobia and glare. Now, just a brief look at atropine. We know that muscarinic receptors are found throughout the eye. They're said to be distributed at iris, ciliary body, sclera, as well as retinal tissue, as well as the epithelial cells. And atropine, which is said to be a non-selective muscarinic receptor antagonist, it is thought to block this receptor site to acetylcholine and other choline esters. However, when it comes to how atropine is slowing eye growth, it is fair to say at the present time that we do not have a good understanding of the mechanism. Initially, it was thought that atropine was bringing about its action via the accommodative pathway because it's paralyzing the ciliary muscle. But what was found was that atropine was found to have an effect even in animal models where there were no muscarinic receptors. In addition, even when there were lesion of the ciliary ganglion, atropine was found to be slowing myopia. So people started to look elsewhere, and they looked at direct effect of atropine at the posterior layers, retina, retinal pigment, epithelium, as well as choroid. But again, it's fair to say that the evidence is inconclusive at the present time. They also look to see whether atropine has a direct effect on sclera. One theory suggests that it possibly has a toxic effect on scleral fibroblasts. Another theories propose that maybe atropine is acting on other receptors, for example, adrenergic receptors. Now, in this respect, we started to look at caffeine. 7-methylxanthine is a metabolite of caffeine, and it was used in clinical studies for myopia in Denmark. Children were given oral doses of 7-methylxanthine, and there was some evidence that seemed to indicate that 7-methylxanthine was effective in slowing myopia. In addition to the human clinical studies, 7-methylxanthine was also used as an oral dose in animal experiments in primate eyes, as well as caffeine. Caffeine 1.4% was also used, and again there was some data that indicated that it possibly had a role to play in slowing myopia. Caffeine is a non-selective adenosine receptor antagonist, and it is thought to release neurotransmitters such as dopamine and alter the blood flow. And we all know from the myopia literature that dopamine appears to have a role to play in myopia. And again, increased choroidal blood flow was also thought to play a role. So we were quite interested in trying to understand and see whether caffeine would have a benefit. So the rationale for us to use caffeine was to see whether when we combine it with low-dose atropine, because clearly we can't use high doses of atropine, so we wanted to try and see whether we could boost the efficacy of low-dose atropine by combining it with caffeine. So for this particular study, what we did was initially we looked at cytotoxicity of caffeine on corneal epithelial cells, and it was not found to be cytotoxic. And then we did short-term studies in adult human participants, and they used 1.4% caffeine. Caffeine was compounded, it was unit dose, and it was used for 7 days. And we looked at various ocular variables, things like looking at redness, intraocular pressure, and we found that there was no effect of caffeine on ocular tissues. Thereafter, we moved to a prospective longitudinal clinical study. This study was conducted in Vietnam. We enrolled children aged 6 to 13 years, and we looked at myopia from low to -6 diopters of myopia. So what we did in this particular study was to randomize children to 3 groups. We used 0.02% atropine because there was clinical data that indicated that 0.01% atropine was not effective in slowing eye growth. With the dose where we found that there was a change with respect to axial elongation, and then we wanted to add caffeine to it to see whether it would boost the efficacy. So we had 0.02% atropine as one group. The second group was randomized to 2% caffeine. We used 2% caffeine because it was the maximum soluble in water. And then we had the third group, which is the combination group. And at the same time, we had a parallel group wearing single vision lenses only, or the control group. So we monitored these children for 12 months. They were examined at frequent intervals through this 12-month period. They were seen at 3, 9, and 12 months. So what I have here is the data with respect to 12 months. So we have the axial length change in the bright orange bars, and the yellow bars refer to change in spherical equivalent. What you see here is that in the single vision lens wearing eyes, the eyes progressed by 3/4 of a diopter and 0.37 millimeters. And we know that this is roughly what we would expect to see in an Asian population. So the control group was performing as expected. Now, what we see with the caffeine group is that the caffeine group had a change in axial length and spherical equivalent, very similar to what we see with the single vision lens wearing group, and there were no differences between the group. Now, both the atropine and the atropine alone and the combination group, you can see that the change in axial length as well as the change in spherical equivalent is much lower in comparison to the caffeine alone and the single vision lens wearing group, and they were significantly different. However, when we look at the atropine group and the combination group, there were no differences. In other words, although we went into the study expecting to find that caffeine would have a role in terms of slowing progression of myopia, what we see here is that caffeine alone had no effect on myopia whatsoever. And when combined with atropine, it was no different to the change in spherical equivalent and axial length that we see with atropine alone. Or in other words, using caffeine did not give us any benefit with respect to slowing myopia progression. Now, what we did in that particular study was also look at the other factors that were important for us, because that's how we started. We said, look, we want to try and improve the efficacy whilst making sure that there are no side effects. So we monitored children for accommodative amplitude as well as change in pupillary diameter. So what I have here is the accommodative amplitude at baseline. So we've got the 3 groups where children were using atropine, combination, caffeine, and the single vision lens wearing group. And you can see here that there are no differences between the groups. At 3 months, as expected, we see a lowered accommodative amplitude in the groups that received atropine. But there appear to be no differences. There was a slight difference with respect to the combination group where they had slightly higher accommodative amplitude, but overall there were no differences. And we see the same pattern at further follow-up visits. But in other words, from this data, we see no impact of caffeine on amplitude of accommodation. But when we looked at the pupillary diameter, we found some interesting data. So here again at baseline, so this is photopic pupillary diameter. We checked the pupillary diameter by projecting light of 300 lux at the eye level, and we measured the pupillary diameter with Oculus Spark machine. So what you see is that the photopic pupillary diameter is approximately 3 millimeters at baseline across all the groups. Now, at the 3-month visit, so the single vision lens wearing group came in only for 6 monthly visits. At the 3-monthly visit, we looked at the groups that received the drops. And what you see here is that the eyes that received caffeine, they look very similar to what we see at baseline. The eyes that received atropine alone, you can see an increase in the pupillary diameter by nearly 1.2 millimeters. Now, interestingly, what we saw was that the eyes that received the combination therapy, atropine with caffeine, they seemed to be somewhat midway. So they did have an increase in pupillary diameter, but the increase in pupillary diameter was not as much as what we saw with the atropine group alone. And then we see the same pattern at 6 months, 9 months, and 12 months. So what we see is that when we combine caffeine with atropine, the pupillary dilation that we see is less than what we would see with atropine alone, and it's less by 0.5 to 0.6 millimeters with respect to the photopic pupillary diameter. We also checked the mesopic pupillary diameter. Now, with mesopic pupillary diameter, the pupils are generally large, so the differences are a little more difficult to appreciate than what we saw with the photopic pupillary diameter. So we see here that the mesopic pupillary diameter is 6 millimeters, approximately 6 millimeters across the groups. But again, we see a similar pattern. But because the pupil is large to begin with, now the difference is slightly smaller than what we saw with the pupillary diameter, and it is roughly 0.2 to 0.3, depending on which visit we are looking at. But again, we see that when we use atropine in combination with caffeine, the pupillary dilation that we see is less than what we see with atropine alone. So this tickled our fancy, and we wanted to try and look into this a little bit more closely. So what we then did was to follow it up with what we call a temporal variation study. So we switched to adult participants. We took in 15 adult participants, and we ran a crossover clinical study where each participant tested all the 3 combinations, which is atropine alone, atropine in combination with caffeine, and caffeine alone. And here for this particular experiment, we used a slightly higher concentration of 0.05% atropine. So what we did was we put in a drop and we monitored the eye immediately after baseline, immediately post installation of the drop, 20 minutes, 40 minutes, 60 minutes. And then we got them to come the following day, and then we tried to see at various time intervals what the pupillary diameter was. So here what we see is that immediately post installation of the drops, there's no difference between the groups or no variation in the pupillary diameter in comparison to the baseline pupillary diameter. And then we look at the 20-minute data post-installation. And when you look at the caffeine group, that is the gray bar, again, there is no difference in pupillary diameter in comparison to baseline. What we see with the atropine group is that nearly 14% of them are showing approximately 2 millimeter increase in pupillary diameter, 20 minutes post-installation. But we do not see that in the combination group. The combination group is still trending at about 1 millimeter increase in pupillary diameter. Now we go to 40 minutes. Again, you can see that there are a lot more of the eyes in the atropine group alone that are showing a bigger increase in pupillary diameter, whereas the combination group seems to be lagging behind. And at 60 minutes, in the atropine group alone, there's some eyes showing as much as 4 millimeter increase in pupillary diameter, but we do not see that in the combination group. By the way, I should mention that this was a double-blind trial, so the examiners did not know what the participants were receiving. And then we got the participants to come back the following day, and we looked at how they were tracking back to baseline. And again, basically, with this particular slide, you see that day 1 at 9 in the morning, there's more eyes in those that received atropine alone that are showing an increase in pupillary diameter. And over the day, you can see that more of the combination eyes seem to return to normal rather than the atropine eyes alone. So this is just a summary of the data, and this graph here looks at the atropine group alone and this is the combination group, and this is the caffeine group. And what we again see with this data is that the group that received atropine seems to have a greater increase in pupillary diameter. And generally, when we look at the size of these box plots and compare that with the atropine to the combination alone, what we're seeing is that the combination group seems to have a much tighter controlled response in comparison to atropine alone. And again, basically, overall, the data is telling us that there was lesser pupillary dilation with the combination than with atropine alone. The difference in pupillary dilation, again, was about 0.5 millimeters or less. That's where it seems to be. And at this point of time, we do not understand the significance of this 0.5 millimeter difference in pupillary dilation, and clearly much more work needs to be done to try and understand the mechanisms as well as the significance of this data. The possible mechanisms with respect to why we might be seeing this sort of a response could be that caffeine is competing with atropine for the muscarinic receptors at the iris, and therefore reducing the dilation effect that we are seeing. Possibly, caffeine is inhibiting the acetylcholinesterase, or trying to increase the concentration of acetylcholine, which then competes with the muscarinic receptor sites with atropine. Or the third possibility that we considered was that maybe there is reduced permeability of atropine when combined with caffeine. But we think that this last route is unlikely because we saw that the combination group was effective in slowing eye growth, very similar to what we saw with just atropine alone. However, this was an interesting finding. We did not set out, as I mentioned, our aim was to see whether we could have increased efficacy when we combined caffeine with atropine, but we found something completely different in this particular trial. And I'd like to finish there, and thanks very much for your attention. And I'll stop sharing my screen.
Prof Cheng, I think you're muted still.
Okay, thank you. Yeah, thank you, Ray. So great, Professor Padmaja. So we had the opportunity to hear from you of your interesting work. I mean, both topics are very interesting. The caffeine effect on the myopia, and also the important and convenient convenience of using the axial lens to measure quantify myopia. Okay, now may I introduce my colleague and also our panelists, Dr. Ray Naja and Dr. Sun Chen-Xin, to join us for discussion. So Ray and Chen-Xin, you may want to introduce yourself first before you ask Professor Padmaja any questions. So we can start with Ray and followed by Chen-Xin. Okay.
Sure. Thanks, Prof Cheng. So hi, everyone. Prof Padmaja, thanks a lot for a very insightful talk. I'm Ray Najar. I'm assistant professor in the Department of Ophthalmology at NUS. And I'm basically the organizer of the webinar series, I think. So Chen-Xin, leave it to you to introduce yourself, please.
Hi, Chen-Xin here. I'm a pediatric ophthalmologist at NUH with strong interest in myopia management for children. And yep, let's go ahead with the Q&A.
So Ray, you have any question for
Can I? Yeah.
Padmaja? Yeah.
Yeah, I think I can start. I have actually two questions, if I may. First it's very interesting to see the axial length results. I'm just wondering from a research perspective, is axial length, or at least the models that you're suggesting, Prof Padmaja, enough for us to assess, for example, the effectiveness of atropine or any other treatment for myopia progression or myopia onset in children. Do you think we are there yet? Like to say we can forego cycloplegic refraction because it's tough and then go with the formulas that you're suggesting for research?
Yes, I mean, in terms of, we do know, and there's a fair bit of evidence in the literature. So when an eye is already myopic and you look at the change in spherical equivalent and change in the axial length or vitreous chamber depth, as they measured many years ago, there appears to be a good correlation. Or in other words, whatever we are seeing in the myopic eye is coming in because of increased axial elongation. Therefore, axial elongation is a good way to monitor progression of myopia. And in fact, it's the only way to monitor progression of myopia when you use a strategy like orthokeratology. So yes, where possible, I mean, we do understand that spherical equivalent refractive error can also be used to monitor progression of myopia, but where possible, we should be able to use axial length values, because from whatever we see, both in terms of repeatability, accuracy, and ability to monitor progression, axial length values do provide us with good value, especially in the research setting.
Yeah, I think you answered both of my questions at the same time. So, Chen-Sing, any
Maybe
questions
if I
from your
can
side?
follow, I think what Ray was implying was when we run the study, we still do both axial length and cycloplegic refraction. So since axial length is so good, why don't we just forget about doing cyclo?
To monitor progression, yes, but to be able to, which is what I mentioned, I mean, for us, because we still rely on spherical equivalent refractive error to be able to decide what we have to do with respect to the treatment strategy. They still require correction. So you do need, I don't think we can do away with that, except in the case of orthokeratology, where you're just molding the cornea and using the change in values to try and figure out where you go next. But yes, I would think that you would need both values.
Yes, agree completely. I think I'm fascinated by both topics. And I think there is very clear evidence from your work that both the growth ratio, the annualized growth rate, as well as percentile chart are very useful for not only ophthalmologists, but even the healthcare professional, any eye care professional, to be able to plot that and educate the parents and patients on where they are at and what the progression is going. My question is, this kind of growth chart is very common for height and weight in the pediatric health. So in many countries, they have standardized percentile growth for height and weight. However, I don't see that happening in the eye space. That have not been incorporated into, at least in Singapore and a lot of the Asian countries, in terms of a national kind of health prevention. Because for obesity and short stature growth, we have very, very good guidelines to screen the patients and plot them as they grow. But I'm just wondering, when is this going to happen in the axial length space? Do you have any insight on that?
So one thing I wanted to say with respect to axial length and the value of axial length to assess the state of the eye, in that respect, we know that ALCR is more accurate than axial length. I just wanted to make that point.
Yes.
ALCR is more difficult for I mean, to translate that to normal practice, because we are talking about a ratio. So axial length values are much more easier to understand. In terms of reference curves, either based on axial length or ALCR, it definitely is possible because there is large amounts of data being collected on axial length, especially with myopia increasing in prevalence. A lot of countries are looking at axial length values and setting up reference curves. I know that there's some work that is being done in China where they're looking at axial length and ALCR percentile curves as consensus statements. But again, it goes back to what I mentioned, that they are regional specific, which means that we've got to establish these curves for the various regions.
Yep, and I think in the Q&A session, a lot of people are interested about your caffeine and atropine combination study. So there are some questions about overall safety of caffeine in children. Is there any adverse effect on growth, development of the kids?
Yeah, that seemed to be a concern, but when we looking at the drop and we are looking at the amount of caffeine that is delivered with this eye drop, and we are talking, the eye probably is like 40 microns or less. The amount that is delivered to the eye is quite small and insignificant. For example, if you compare it to a cup of coffee that is had. And we also looked at the half-life of caffeine. It is rapidly excreted out of the system. So we believe that there are unlikely to be any significant effects. When we started the study, we looked at all of these aspects, and we felt that any adverse effects related to use of caffeine are quite minimal to insignificant.
All right, sounds great. So I guess the natural next step is probably to look at in patients who have photophobia with atropine use. Is that the next step that's going to do? We should add caffeine to the atropine?
Yes, so I mean, we left it where we left it, which is, yes, we ran the study. We started off, like I said, trying to understand whether it was going to boost efficacy, but we got a completely unexpected finding. And we left it where it was, which was, yes, we got this change. Now, how does that change relate to exactly what you're saying? So if we have a 0.5 millimeter change, is that going to be helpful with respect to reducing the symptoms associated with photophobia? Is it going to have an impact on vision? Is it going to be helpful with, for example, mesopic visual acuity? All of that needs to be explored.
Right, very exciting. And just one more question from the audience. Was there any adverse effect that were reported from the use of caffeine in your studies?
We did not see any adverse effects. We did monitor children reporting, for example, photophobia, blurred vision, and the incidence of those occurrences were no different between the caffeine group and with the atropine group, the caffeine group, and the combination group. They're less in the caffeine alone group, but they were no different in the atropine and the combination group.
Sounds great. I look forward to having that in my clinical use soon, because we do have a number of children on, especially the 0.05% atropine complaining of photophobia. And right now, the only way is for photochromatic lenses or tinted lenses. So if caffeine could fix that issue, that would be very useful.
We don't know where this will go. Clearly, much more work needs to be done because, as I mentioned, we simply looked at a concentration which we felt was low. It was soluble in water because we were using unit dose solutions. We didn't want to add any preservatives, because we didn't want it to impact on the study findings. But clearly, a lot more needs to be done, I think.
Yep.
We have a question on the normative data set of the axial length in Singapore, and maybe Chen Xin to help to answer the questions.
We unfortunately for Singapore, we actually do not have a large scale study to collect the normative database. We do have longitudinal data from the existing clinical trials in children, for example, the MySight contact lens trial and the atropine trials. So we have a spread of axial length growth in these trial children, but we don't have a big kind of epidemiology survey of all the different axial length in different population. So answer is we don't have a specific data for Singapore, but I think we can reference on database from countries around us, hopefully. I don't know. Prof Padmaja, shall we start a Singapore database? You're muted, Prof.
Sorry, I was saying it sounds a good idea.
I do have another question on the caffeine clinical trial. First is I saw your design of a clinical trial. The sample size since is not a very big sample size, right? So the first question is that is the sample size is the issue? If we increase sample size, are you able to detect the difference between group? And my second question is that like the atropine, right? I mean, there's dose response, those are response dependent, right? So is that does the concentration in caffeine make a difference? Maybe you didn't use the right concentration, the concentration not high enough. That's why you don't see a difference between the group.
Yes. So for the first study, I mean, it was meant to be pretty much an exploratory study to try and understand what we are going to get with the combination. And we also wanted to make sure that we have specific number of groups as well, because we had 3 arms with the drops, and then we had a single vision group. So there were a certain number of people we had to enroll within a certain time frame. So we went with the numbers that we had, but the numbers that we had were sufficient for us to be able to detect a significant difference between the groups. So the sample size was definitely based on that. Now, in terms of was that sufficient for us, and would we find the same result again? So clearly, we followed that study with the temporal variation study. So we said, yes, we've got some finding here. It was consistent across all visits, but we wanted to see whether that finding would hold true. And when we did the temporal variation study in adult participants, where we used atropine plus caffeine, we actually went to a slightly higher concentration of atropine. We used 0.05%. In the original study, we used 0.02% because our thinking was, look, did it work? Because the atropine concentration also was quite low, would it work in a slightly higher concentration? Unfortunately, we couldn't modulate the caffeine concentration because it was the maximum soluble in water. And we just wanted to keep that formulation because we were basically doing an exploratory study, so to speak, to try and understand what happened. So we stayed with 2% caffeine. We've got no idea what might happen if you try to increase the concentration of caffeine and redo the experiment. I hope that maybe we'll find a higher difference, which might help us with what we are trying to do. But that's where we finished those set of experiments.
Okay, great. Yeah. So
Can I
yeah, sure. All right. Go
just
ahead.
follow up with one question, because I was thinking about this, and it's gonna be an interesting trial when you increase the dose of atropine. And I feel that monitoring the time spent outdoors is gonna be crucial for that, because if caffeine is reducing photophobia in the participants, so participants who are on caffeine and atropine may actually go out more often than participants who would be on atropine alone. So that will be an interesting study actually to look at, because then the question would be, is caffeine changing the way of life in these children, or is it really mechanistic effect? So that's going to be really, really exciting.
A lot remains to be explored.
Yeah.
Okay, great. I think it's almost come to the end of the webinars, and I want to thank Professor Padmaja again. And time is almost up, and thank you everyone for joining us today. And I wish you all have a good night. And
Thanks very much again.
Professor Padmaja again.
Thank you very much, Prof.
Thank you very
Thank
much.
you, Prof
Thanks
Padmaja.
again.
Thanks,
Bye,
Prof. Chang.
everyone.
Bye.
Thank
Bye-bye.
you.